for this next in the applied analytics seminars, then I'm very pleased to have Theo Arvanitis, who's a long association with HDR UK, one of the stalwarts. I believe this is going to be quite both general and specific, Theo, and focused on radiomics for childhood tumours. So normal rules apply. Theo will give us talk, and then at the end I will help to field questions. It's helpful if you have some questions to put them in the chat as they go through, and then we can just pick them up at the end. So thanks, and over to you, Theo.
Great, thank you very much for the opportunity to present the work we have been doing as part of HDR UK, but also this work has started before HDR UK, but it shaped very nicely within the applied analytics theme. And I have to say it is the work I'm presenting here is the last 10 to 15 years, but we have started this work about 25 years ago in early stages of the ideas we had. So let me share my screen. It's fine. Right. So I'm a professor of digital health technology at the School of Engineering at the University of Birmingham, and for my sins I became the head of Department of Electronic, Electrical and Systems Engineering. I've been associated to HDR UK as an associate director for the Midlands, but before probably you knew my work as part of the University of Warwick. So some of the work I'm presenting here is both from Birmingham and Warwick and other partners within the Midlands group we have. So let me start a little bit by contextualizing the ideas. So let me start with the context, and of course in this slide let's just give the usual buzz we know about the high and growing rapidly availability of large data sets and how we can take advantage of these by using high computer power and AI techniques in order to be able to create a competitive medical imaging industry, but also support the outcomes that are needed for the health and the wealth of individual patients and citizens. So I think for us, during the period of the first years of HDR UK, but also a little bit a few years before that, we had that kind of opportunity to offer through AI new and promising set of methods for analyzing image data so that we can increase our diagnostic ability and certainty, be able to prognose better the progression of disease, and in that way we can provide better clinical management and outcomes for individual patients. So I think that's really the main motivation behind this work. So the use case I'm going to give today relates to the characterization of childhood brain tumors through what we call multimodal functional imaging approaches to this area of research. So in particular, the challenge was to innovate in terms of technology on imaging informatics and data science so that we can non-invasively be able to provide diagnosis, prognosis, but also insights to the management of children with brain tumors. And as part of that innovation we do in the group, and as part of the innovation we have been doing in the applied analytics HDR priority, was to look at the concept of radiomics and AI tools for magnetic resonance neuroimaging for pediatric oncology in particular. This work, of course, has been funded from HDR UK the past 5 years, but before that, the concept started with advanced quantitative imaging, and we have been funded by the Department of Health, NIHR, Cancer Research UK, EPSRC, MRC, and a lot of charities, including the Little Princess Trust charity that has supported the work of the children's, that has been supported through the work of the Children's Cancer and Leukemia Group, which is another charity. The work I'm presenting here has involved partners that they are part of ACA UK, the University of Nottingham, and then in Nottingham University Hospitals, and the University of Birmingham, Birmingham Children's Hospital, and of course, my previous institution, Warwick. But it is a national exercise, and we had partners from many, many areas. So I'm very indebted to all the work of the co-investigators and investigators that have helped that work, both in the technical and in the clinical sphere of the challenges we have been looking. So why magnetic resonance functional imaging? And I will define functional imaging is not what a lot of people think is not functional MRI. It's slightly different. Imaging, magnetic resonance imaging is very important for pediatric tumors, especially at different levels at the point of diagnosis when a tumor can be identified, like in this case here as this interesting blob that appears in the middle of the image. After a therapeutic approach has been taken, usually an operation, a surgical resection of the tumor, where we can see the progression of the disease and how much we have managed to confine this problem. And further, after radiotherapy, which is another therapeutic approach that is taken, and then we can see if the tumor has been completely removed or still remains, and we need to take further approaches to the therapeutic management of these children. I will come at the end and say how much we have achieved this overall in the battle of improving survivability for children in this area. But one of the biggest challenges that we have with imaging, if we took the traditional approach of trying to do the visual discrimination of different types of tumors, is that this is not easy. So on the top here, you see three typical images that we take from a particular sequence, T2-weighted MR sequence, of the three typical groupings of childhood brain tumors. The groupings are identified, or types are identified as the medulloblastoma, astrocytomas, pilocytic astrocytomas, and ependymomas. These are the typical groups of tumors we look at. But if you look at the images, it is very difficult to discriminate, except the position and structure, from a visual point of view, that these are different types of tumors. And actually, we need to do a biopsy, an invasive procedure, to be able to start discriminating these to make a definite diagnosis. So what we have been trying to do, in addition to the conventional imaging that I just showed you, which, as I said, gives largely information about the tumor structural location, we have started looking at approaches which we collectively term them as functional imaging, because what they try to do, they try to look at quantitative information that potentially can tell us more about the cellular structure of the tumor, the metabolism, the vascularity, the ultrastructure around the tumor, the angiogenesis of the tumor, which means that the tumor can grow based on the supply through the blood vessels. So we have been looking at these approaches that are based on magnetic resonance imaging, but they're more specialist approaches where we use, for example, diffusion properties for looking at diffusivity of the water, which tell us something about the cellularity and the tissue ultrastructure, perfusion, which tell us more about the vascularity of the tumor, metabolic profiles through spectroscopy and appropriate quantitative measures of this, and combining these as part of what we call a multimodal protocol. So the definition of radiomics that a lot of people give might be mainly based on particular texture analysis of these interesting features we see in images, but we like to take it a little bit further to identify quantitative features that we can put as part of the pipeline of radiomics to be able to do a better diagnosis, prognosis, treatment planning, and monitoring of the disease. So that's really the approach we have been taking. Now, why this is important, I will give you an example through one of the functional imaging techniques. I will take the example of magnetic resonance spectroscopy. Again, we use the same MRI scanners that we use for brain imaging. But what we do after the conventional MRI, we are able to identify a region of interest, and on the basis of a particular pulse sequences we use, we are able to acquire a spectrum that tell us about the metabolism within that area of interest. And then we are able to take this out of the scanner and be able to process it and potentially use it as part of the pipeline to make decisions in terms of classifying disease from a point of view of different types, or seeing how badly it will progress and what are the prognostic factors of that. Just again, coming back to the three typical groups of different tumor types we have in children. As you can see, this is a typical spectrum of a normal brain where we have important metabolites like this peak here, which is NAA, which tell us about the health of our neurons, choline, creatinine, inositol, lipids, which tell us more about the metabolism of the brain. If you just simply look at the profiles, you can immediately see that there is already a differentiation on these peaks. And potentially this led us to the idea that if we are able to quantify this appropriately and put them as part of machine learning exercises, this was as early as 2008, we did this work, we will be able to discriminate tumors diagnostically. And indeed, we developed technologies that are doing the automatic analysis of determining the quantities of molecules that are presented in this magnetic resonance spectroscopic data. And we used an approach which was based on least squares, automatic quantification for doing that in vivo. So be able to characterize the metabolism of the tumor at the point where we don't need to do biopsy. And that was our immediate effort from the beginning, is to reduce as much as possible the invasiveness of the diagnostic approach. And actually, if you are interested to look at this early work, which has led us to collect useful data for the radiomic pipeline, the whole system that we have developed is available at SourceForge, and there are 2 publications which I'm very happy that if the slides are made available, that to go through these with any of you if you're interested. But indeed, by doing this approach, we were able to fit the spectra into simulated basis sets and be able to accurately measure the metabolic quantities within the spectra of particular areas of the tumor. And of course, this could have be done at an area, a small square, a voxel, a cube, but also a larger area of the brain by transforming magnetic resonance spectroscopy to magnetic resonance spectroscopic imaging. So that's one of the interesting approaches. But the early work we have done in terms of using AI as part of this quantitative approach to characterize tumors was on the value of the diagnostic approach we take with childhood cerebellar tumors. And this is a recent publication we have done, but by looking at these metabolites and throw them into appropriate classifiers, we're able to clearly identify these groups of tumors. And of course, this, as we argue within the paper, is very useful for radiologists and oncologists in terms of determining early potential diagnosis before the need of a biopsy. And potentially the biopsy could happen at the point of resection of the tumor in a surgical intervention where the finding could be verified. So I think that was one of the interesting things we have done since 2008, and we have reached that point in the past almost 20 years of work. But not only for diagnosis, we have started identifying, interestingly, that various metabolites. So, for example, in this work that we originally published as part of a review in Nature Reviews Clinical Oncology in 2012, we have been looking at various metabolites that tell us something about the progression of the tumors. And actually, we found, as an example here, the citrate as a metabolite tell us that astrocytomas are having really poor prognosis, and these metabolites tell us that potentially the progression of the disease will be difficult, and appropriate decisions can be made in terms of what needs to be done in terms of therapeutic options for these particular children. So already you see that the quantitation approach allow us to be able to tell something about diagnosis and something about prognosis of these tumors. And of course, we have expanded this in not only one example metabolite, but in many metabolites. And again, in the same year, we identified that unfortunately increased cyanositol and increased lipids have a very, very bad prognosis. So these are typical Kaplan-Meier curves where we see that an increase lipid concentration actually shows that the survivability probability reduces even up to almost 50%, and the same with cyanositol, even worse, 40%, while an increased presence of NAA, which tells us the health of the neural tissue, increases the survivability actually prediction for 80%, while glutamine is also a good predictor. So immediately you see the power of this quantitative information as part of putting these into analytics tools and machine learning tools for being able to diagnose, prognose childhood brain tumors, and on the basis of that, decide about the application into clinical decisions. So I think radiomics gives us the opportunity to take this quantitative data and that comes out of functional imaging and use appropriate AI-based approaches to be able to do an interesting pathway that allow us to take interesting features out of this data, quantitative features, combine these features with clinical and other relevant information, including genomics, to be able to use this as part of building models, AI-based models that allow us to make specific clinical decisions in terms of diagnosis, prognosis and monitoring of disease. So what I will try to present to you is the opportunities and also the main challenges. We have been looking at this pathway, especially the radiomics pathway in terms of image acquisition, data curation, the challenge of segmentation, and still what challenges exist there, the type of feature extractions that we can achieve, select, and then how we use this to build models and have particular applications that relate to functional imaging. So let me start with the data acquisition. It is very important that we achieve this approach of collecting data by using multi-center studies. Why I'm saying that is because especially childhood brain tumors are almost a rare disease. We don't have, thankfully, so many every year, and some types are more rare than others. But equally, I think it is important that imaging protocols can be adopted by different centers that have different varying capabilities without compromising the image quality. So as part of the work of understanding how we can use this data, we have been trying to, again, with international societies and, for example, the European branch of the International Society for Paediatric Oncology, to create appropriate guidelines for imaging these patients with central nervous system tumors and brain tumors, which included all the functional imaging approaches I explained. And it is very important because, for example, you can see in this extract image from the publication of the protocol that if you don't clearly identify that something is an artifact, so in particular in this area here, we see the effects of flow, and actually the effects of flow identify what might not help us distinguish what is a solid tumor and what we need to segment so that we are able to take the data out of it so that we can analyze it. So it is very important that we are able to do that, and imaging protocols have helped us to that type of harmonization. But as you will see in a moment, we need to do that harmonization at the later stages of the processing. An important part of the exercise has been also in developing appropriate repositories so that we are able to collect these data as part of studies. And of course, with the CCLG, the Children's Cancer and Leukemia Group, and the support of HDI UK, we have developed a large repository. Now it's the largest in the UK that has about 600 cases, or 600 patients with different cases of brain tumors. And this is a repository that is comparable to repositories internationally. And this was not only part of the analytics work we do, but also the infrastructure work we do in terms of taking the data, curating it in particular formats, and make it ready for analysis. So that's something that we are very grateful to HDI UK for what they have supported us to do. And when we have the data, then the imaging data sets as they are need to be somehow, we need to identify the regions where we need to work on, be able to later on normalize them so that we can do the analysis in a pooled way, because we get this from different centers, then move to the texture analysis and extraction of features out of the texture analysis and the other quantitative features that then through appropriate techniques for feature selection, we can throw these into a supervised classification or even unsupervised classification in some cases. And the challenge of segmentation has always been a big challenge for the radiomics pipeline. So that's really something that has taken a lot of our efforts. And although segmentation is happening for different applications of brain imaging and neuroimaging, I think the challenge of segmenting tumors, which are heterogeneous and sometimes diffuse in the other tissue of the brain, is quite great. And again, for that, we have been also looking at approaches which are based on machine learning, or even, as you will see in a moment, transfer learning based on deep learning, that allow us to be able to segment the tumors in a more accurate way by combining techniques that were based on graph theoretical approaches and gradient vector flow snake boundary approaches as part of the effort we have done. And this is as early as 2012, but as we progress, we have been training through deep learning, through data sets on adult tumors, segmentation approaches based on different deep learning algorithms. Here I show you an example of the medic on adult gliomas, where we were able to achieve good segmentation up to 90% accuracy of the whole tumor, to the also identifying the peritumoral edema and tumor core, and be able to identify components of the tumor, because as we said, the tumors are very heterogeneous in that. And again, most recently, we have done a review of what is happening in this area, and there is plenty of work in terms of transfer learning, again, because we cannot work or we cannot achieve deep learning with the limited data sets we have, but we can do transfer learning or approaches where we create synthetic data sets. One of my colleagues, I think earlier last year, discussed about our approaches of creating synthetic data sets for both clinical and imaging data as part of being able to train deep learning algorithms in the future. Of course, the ground truth is very important, and a lot of the effort is about annotating and labeling the particular parts of the brain we're looking at. And of course, this is an ongoing effort for the work that is happening as part of the radiomic pipeline. Let me move now to the important part of feature extraction. So a lot of work has happened in the field in terms of being able to try to standardize the potential features and classes of features that we can use in terms of what we extract from images. And I've shown you the examples of quantitative features that we extract with functional imaging. But in addition to that, we can take information about the morphology, which describe geometric properties, the intensity-based features, which describe at different level, as you will see in my next slide, ways of the homogeneity or heterogeneity of the tumor, and these features that describe both the spatial complexity and the relationship between the neighboring pixels can be used together with quantitative features as an input to that data fusion we're doing in terms of building technology that allow us to classify tumors for diagnosis, prognosis, and disease management. So that's really the concept behind the feature extraction. So different features, radiomic features, can contain different meaningful information about the tumor biology. And there is a very interesting piece of work that has happened, not only in brain tumors, but in breast cancer. And a very good practical guide for people who want to get involved in radiomics has been published in 2021 by Sherrod and the colleagues at the Radiographics periodical, which identifies the set of features that can and groups them in terms of morphology, in terms of histogram, gray levels, in terms of different texture, second and higher order texture features, or based on the modeling of this and what they mean for the biology of the tumor. And actually, the combination of these, as I said at the beginning, together with the quantitation that we can, the quantitative features that we can add there, can become a virtual biopsy, can non-invasively allow us to do the analysis of the whole tumor or parts of the tumor, at different multiple time points. You can imagine this is extremely useful for the case of children, so that we avoid the invasive approaches to them, and we can follow the progression of the disease at different points in terms of being able to analyze this better. And this is where the approach of data fusion comes in. So using the functional imaging, structural, perfusion, diffusion, magnetic spectroscopy, together with clinical information that we have about a patient, potentially corroborate this with wherever available genomic information from individual patients where we have extracted or resected the tumor at a later point and we did genomic transcriptomic analysis, or even a higher resolution magnetic resonance spectroscopy. We can combine this information to be able to build appropriate models so that we can make particular decisions. And let me go into, and here is where the work of HCI UK in terms of its infrastructure is very important, because again, this type of databases can be supported from what we have been doing, not only in this area, but in other areas of diseases, and hopefully that work can continue in the future. And of course, in terms of building appropriate models, once we have the collection of the data and we have curated, then we can identify the appropriate statistical models to predict whatever our question is, if it is diagnostic or prognostic. And usually we take the imaging, the radiomic, the quantitative imaging, and the clinical features together to be able to do that prediction. And of course, the aim is to try to generalize as much as possible these, although in some cases, there isn't only one model that fits everything, but equally determine what we have created by validating these with new test data. Although in the case of childhood brain tumors, because we don't have a lot of cases, we try to use cross-validation and hold-out methods to be able to validate these techniques. So model building is quite important as part of that. And I will give you an example of what we have done in terms of being able to look at imaging features and then combine them also with other quantitative features, in particular doing 3D radiomics. So be able to collect information from intensities and different different orders of features, statistical orders of features from a 3D volume rather than a 2D slice. And doing that, we have been able in 2018 to be able to have a good classification accuracy on three-dimensional trained SVM and neural networks based on textual features that used histogram statistics, first and second order statistical features, and trying to compare this with different supervised learning approaches. And we came out that SVM and neural nets gave a very good classification performance, considering that radiology classification, visual classification, is far more lower than 90%. It's around 65, and sometimes is even more difficult. And improve accuracy from two-dimensional classifiers of about 19%. So that shows you the importance of combining these features appropriately and using the appropriate models for this approach. But this was for the diagnosis and the ability of us to look at different groupings of tumor, but also within a particular group of tumor, we will be able to use three-dimensional texture analysis to predict survival on medulloblastoma patients, and we identify 15 features as significant features to be able to tell us how well children might survive on particular subtypes of features rather than compared to other subtypes of subtypes of the tumor compared to other subtypes of the tumor. So that's really an example that was as early as 2018, and you'll see later on in my presentation, I give you an example of a more recent piece of work. Now, in terms of technology, we can do this with classification techniques, which are working at the local level. But as we have been doing this in a multi-center approach, as early as 2009, we have been discussing the idea of being able to do things in a federated way and use approaches of federated learning. And at the time, we developed an agent-based approach of being able to classify these tumors for diagnostic purposes in particular, but also for prognostic purposes through the network in different contributing centers without the data leaving the centers. This is something that we have been discussing also in the context of HDR UK in other examples. And some of that work was also having interesting guiding classification requests and rules based on the understanding of the knowledge of the domain. So we have been using some other interesting approaches that were helping us to do supervised federated learning in a particular way. As part of model building, there are still a lot of interesting challenges, and I just wanted to, as a small parenthesis of my discussion of what we have achieved, is to say that within the MCI community, there is the brain tumor segmentation challenge, and every year there is always a new challenge presented to the annual conference to see how we can improve the way we segment these tumors so that we are able to do better radiomic analysis or even better visualization of these tumors. So that's something that is still live in the field, and I think it is something interesting to a lot of our early career researchers, but also the late career researchers like me to continue. And of course, as part of this exercise, we have seen interesting approaches of improved segmentation based on deep learning or convolutional networks, three-dimensional convolutional networks. And here are some examples of work that is happening in the field. And as you can see, the MCI conference and the medical image analysis publications have quite a lot of that work. Why all of this is important, why it is important to build this important information is because from an early stage, we realize that this has an important clinical application. You can be able to make appropriate clinical decisions. Here's an example. A typical problem we have at the progress of a therapy, especially after radiotherapies, we're not sure if indeed the tumor has progressed to be eliminated or it has relapsed. The imaging is not always conclusive, the structural imaging, although you might see some changes, you're not sure about that. The combination of features from quantities, from magnetic resonance imaging, diffusion, perfusion, has allowed us to understand that in this case, the tumor is still present and we don't have appropriate progression in terms of the reduction of the problem. And that's still a clinical issue that affects the way we manage the disease. So I think this type of work is essential from this point of view. And of course, we have seen how we can improve this specific approach into be able, again, using advanced technology. So here is how we use diffusion weighted imaging. This is just the progression of the early work we have done in being able to use these features that allow us to distinguish actually the three different types of tumors by using a particular quantitative feature, which is diffusion coefficients. And in terms of prognosis, in the case of medulloblastomas, we will be able to predict survival and the particular subtypes of medulloblastoma cases where a particular subtype has really a very bad survival. When you look at the overall survival probabilities around 75%, but one subtype is really worse compared to the other subtype, which is really good. And that is important when clinicians make decisions about the next therapeutic interventions they need to know to take. And of course, putting this into clinical decision support systems has been the important clinical applications of how we take these radiomic and quantitative image analysis into clinical practice. So this is an example of the work that has been developed at Birmingham Children's Hospital with the leadership of Professor Andrew Peat, who has been my collaborator for many, many years. And we have supported from my team in putting and developing this particular clinical decision support for its use and translation in clinical practice. So we hope that this will be a reality very soon for clinicians, and not only in the UK, but across the world. At the end of the day, all this work is about how to improve impact in terms of improving the quality of life of children with this problem. And actually, if you look at the current statistics, unfortunately, we still, Cancer Research UK and CCLG have statistics up to 2016. Will be interesting to see what happens after 2016 with a pandemic in the middle. But you can see that since the 70s up to the early 2000s, we have had an amazing improvement of survivability of from 36% to 76%. And although still some of the brain and the associated brain tumors are still quite challenging in terms of survivability, the overall survival of children's cancers for 5 or more years between 2012 and 16 has been around 84%. And I hope that we can improve far more better on that. And this is what the opportunity we have with radiomics and quantitative imaging through AI can bring together. And it brings together, interestingly, the human capital of a lot of stakeholders, including the specialists from the imaging community, the AI and health data scientists, but also the partners from building that support the delivery of care in terms of integrated care, health professionals, the international field, but also the patients and the public, because the patients and the public have been supportive of this work over the past 20 odd years, and this has helped us to progress the work, and with university-led research, but also with industrial national-based research such as ASIA UK or the IBSI initiatives, the input of industry, and the strength of being able to connect data and make it interoperate through different standards that are important for imaging. We're able to deliver an AI data-driven ecosystem for medical imaging that is good for improvement of healthcare. So I think, as I said throughout the talk, there is increased evidence that shows that the AI-based radiomics techniques can aid diagnosis, provide non-invasive prognostic biomarkers, and help the treatment and in terms of planning and monitoring brain tumors. There are a lot of challenges remaining in the way we incorporate these techniques into the routine clinical practice. And of course, this is the role of what we have done in HDI UK, but also in other initiatives to be able to collect robust data and do multi-center clinical trials. And I think for us, the opportunities of this type of research relating to radiomics is that these AI technologies can address significant clinical need. At least what we need to try to do is to do at least as well as the existing standard approach. So we need to demonstrate of statistical non-inferiority rather than anything else. And substantial clinical testing must validate the new technologies and be able to see these across different clinical situations and variation populations, and be able to have this technology translated into clinical practice through appropriate regulation. So these are interesting challenges that are not specific to radiomics, but relating also to the radiomics work. But I believe that the radiomics can provide improvements in patient outcomes, patient quality of life, and practicality in the way we can improve healthcare delivery and of course reduce healthcare system costs. So with that, I would like to conclude my presentation and thank you for your attendance.
That's wonderful. Thanks, Theo. That was a fantastic overview. It's a real privilege actually to hear about research that has gone on for so long and so deeply. It's quite rare, and you've seen both the radiomics pathway and the clinical pathway. So that's very good. But let's get to the questions. And we've one from Richard Chin. I'll just read it, Richard, if that's okay. That says, a clinical question that's not uncommon soon after surgery, where there's residual tumor versus post-operative changes due to blood edema and inflammation, that sort of thing. The question is, have there been developments of radiomics to help distinguish one from the other?
Yes, I think probably, Richard, I alluded that when I had my discussion about pseudoprogression. So there are developments at the moment that look at these. We did also this with a bit of quantitative imaging in terms of edema and inflammation, but it's still a challenge, in particular a challenge in terms of when we appropriately collect the data. So this is more of the clinical pathway rather than the radiomic pathway. When is the appropriate time point to collect the data so that we can monitor these changes appropriately? But these techniques potentially can, especially with the advent of functional imaging, can potentially help us to do that.
Oh, Richard, do you want to come back?
Thanks for that, Theo. I actually emailed you about an invitation separately, but what I wanted to ask, I mean, it's usually very soon. I understand the point about pseudoprogression, but it's very soon after surgery, whether there's a decision, if there's a particular tumor type, that complete resection has a better prognosis. And so there's always this question as, you know, immediately, like within the first week or 2 weeks post-operatively, you know, this scenario, do we need to go back or not? So I just wondered if there was anything more in a sort of acute presentation.
As far as I know, I don't know, in children at least, we have not had any particular studies that looked at that. I suspect maybe there might be some limited studies in adults, but I'm not entirely sure if that's the case.
Thank you very much.
Okay, I actually have a question of my own, so just checking everything. Yes, I have a question of my own, Theo, actually. I'm not sure if this is maybe quite a difficult question, I don't know, but as you know, I'm a systemsy type of person. Actually, by coincidence, not too long ago, I've a friend who does radiomics across in the US and worked in a hospital as well, and she was laughing and saying that for markup she was talking about, and now her students cannot believe that it wasn't automated, because it's just something that they do now. It's part of their routine. And so my question really is, I mean, you've done a lot, but it's because you can look both ways. You can follow the radiomics pathway, and you understand through association and through experience the clinical pathway. But what broadly, without spending a day talking about it, what broadly do you think it would take to make this be something that really was routine across those pathways? What are the obstacles, maybe?
Okay, I think the challenges are in the various points of the pathway. So be able to automatically segment and extract the information in a way that doesn't miss useful elements, and also it segments the heterogeneity of the tumor is still a challenge. So I think that's something that we need to improve a lot. We are closer to automation of that, but again, still it depends very much on testing the ground truth by using humans in the loop. I think that's the challenge. The other important element is to be able to do that link between the knowledge we have in terms of the biology, but also the clinical presentation with the radiomics features. And there is a lot of interesting work to be done on that, to be able to tackle what a radiomic feature means. And is it a single feature or a combination of features that tell us something about the biology or about the clinical presentation? And I think there's still work to be done on that area. In terms of the classifiers and the technologies, I think we are getting better. We just need to look at how we do more appropriately the model building for this. And I presume that's why if I have some of my engineering or even computer science students, they always say, why don't we do this automatically? Because it's straightforward from point of view of building the technology, which is fair enough, but it is how you make sense of the inputs and the outputs of that particular pipeline. And I think this is where the challenges are. I have to say, we have improved quite a lot into this pipeline. And the only other thing that is important is the normalization of the data. So if data is collected from different centers with different protocols, or even if the protocols are the same with different systems, then that's also a challenge we have to look at. But again, we have technology and techniques that can help us to improve on that.
Great. Terrific. It's a great cause for optimism. Any more questions that anybody has right now? I see we're nearly up to the limit of time in any case. I see no hands. I see no more questions. It was a very comprehensive talk. So thank you very much, Theo. That was great. Thanks very much, folks, and see you again soon. Bye.